Okay, so we may as well get started. The recording of this really, it just gets stored on the WHO's CAP, the Knowledge Action Portal. So we've just in the past recorded these, and then we store them like as a minute meeting for everyone. All right, I'll just do that. So so that we've got a recording and we can go back and listen to people's stories if we want to learn more. So I will just share my screen briefly and welcome everybody to the CAP. This is our is that working okay, Katie, that screen share?
Yep, looks good.
Great. And welcome everybody here. I'll just close that there. This is our 8th Community of Practice meeting on the road to 2030. Mates, maximising access to essential supplies for children. And this is for the African, American and European regions, and just really want to welcome everyone here. Just in Australia, we tend to start with an acknowledgement of country. So I'd like to acknowledge that Clan's headquartered on the lands of the Wallumattagal people of the Eora Nation here in Sydney, Australia. And I'd like to pay my respects to elders past, present and emerging. I've snuck in a photo there of Colombia as well. We had a club meeting there in March of this year. And Ellie's from Colombia originally, so a shout out to Ellie there, and Paola's going to be talking about the progress they've been making, but it was just a nice chance to share another slide. I think if we start with some introductions, I'll stop sharing my slides in a minute and we can all share some introductions. We've got the agenda there. I'm just going to give a few brief updates, perhaps a refresher on what Mates for Kids is all about. Some updates on the community grants, some recent events we've had, some upcoming events. And then as per our agenda, I'll just go here, we'll be handing the screen over to others to talk. So everyone has the agenda, I think, but we'll just be sticking to the agenda. But if anyone needs to change, please just message us in the chat, Katie and I, and we can change times around if someone has to go early or something like that. Just some housekeeping. If we can stay on mute, unless you've got a question, you can put up your hand or you can just shout out. This is very casual. This is our community of practice for us all to share stories and learn from one another. And please feel free to use the chat as well if you'd like to share some messages and that sort of thing. So back to this, I'll just stop sharing my screen now and go around the screen and we can all just introduce ourselves, I think. And I'm going to start at my top left screen and call people out. So Dr. Ligong, would you like to go first? Or maybe Dr. Phoebe, the team from Kenya.
Okay, thank you so much, Kate and everyone. My name is Dr. Phoebe Wamalwa from Kenya. I'm the chair of Pediatric Endocrine Society of Kenya. And together with us, we have Dr. Saumu. Dr. Saumu, you can put on your video and introduce yourself, and then Dr. Laigong Paul, who is the chair of DSD working group in the society. Thank you. Dr. Saumu. Okay, Dr. Laigong.
Good afternoon.
I think Dr. Salmu. Oh, there you go, Dr. Dr. Salmu, I think, was on mute. We didn't hear. Able to press the unmute? Yes.
Okay. Greetings, everyone. My name is Dr. Saumu.
I'm a pediatric endocrinologist from Kenya. I am the secretary for Pediatric Endocrine Society of Kenya, and also the secretary for the DSD working group under PESC. Thank you.
Wonderful. Dr. Lagong, Dr. Paul?
Okay. Dr. Paul Laigo. I'm the chair of the DSD group in the Pediatric Endocrine Society of Kenya. And it's my team that is undertaking the project, and Dr. Saumu will do a presentation. Thank you.
Great, thank you so much. Dr. Elizabeth?
Hello, everyone. I'm Elizabeth Oyenusi. I'm a pediatric endocrinologist from Lagos, Nigeria. I'm the current president of the African Society for Pediatric and Adolescent Endocrinology. I'm glad to be here. Thank you.
Wonderful, thank you so much. Dr. Salwa?
Yes, hello. Hi, I'm Dr. Selwa Musa, pediatric endocrinologist from Sudan, and I'm the past DSD chair DSD group in the African Society for Pediatric Endocrinology and Diabetes, and the current one, the chair of ASPI CHDSD focus group.
Wonderful, great to have you here. Are you still based in Egypt at the moment, Dr. Salwa?
No, still moving.
I'm still moving, okay.
Yes,
All right.
I'm currently on Oman, yes.
Okay, lovely to see you. Thank you for joining. Ellie?
Hello, everyone. My name is Eli Ruvashkin. I'm a pharmacist currently working with Intersex Asia in a project on evaluating access for medicines in the Asia Pacific region. So I'm devoting my energy and time, and at the moment I'm starting to develop the project for the year to come. And I hope I can work with all of you as we learn to identify ways to ensure these medicines are available in every single country. It's a big task. I mean, that's why CLAN has been doing this important work. And I'm very happy to be able to connect with all of you. And I'm from Colombia, and I am based in Aotearoa, New Zealand. Right now it's 1 a.m. So I'm very glad to be with all of you today.
Thank you, Ellie. And Ellie's been doing some fabulous work with the CAH community in the Philippines. And
Definitely,
wonderful.
that's right.
So thank you, Ellie. Marika?
Yes, hello to everyone. My name is Marika. I'm from Austria, from Europe, and I'm working here in Austria with the CAH patients group. So I have CAH myself, and I'm I'm part of the organizing team of CAH International. CAH International is a loose network of CAH groups worldwide. Yeah, and at the end of the meeting, I will introduce CAH a little bit more. Yeah. So
You're on our agenda.
good to be here and to see you all. Thank you so much.
Thank you, Marika. Kath, Carl?
Good evening, good morning, everybody. I'm Kath. I am the Vice President of CLAN, and I've been working with Kate for a long time, and I'm very committed to the Mates for Kids movement, and in the hope of improving access to medicine and equipment for people living with non-communicable diseases, particularly CAH is of our interest. Great to see everybody today.
Thank you, Kath. And Kath is a brand new grandmother, so that's a really important thing to note. Paola from Africa.
Hello. Well, my name is Paola Duran. I am actually from Colombia, but I'm in Africa right now. I'm at Senegal. I've been here for a few days and I love it. And I am very happy to be here with you today and to be sharing all our work and the things we are doing together. Thank you.
Thank you so much, Paola. Dr. Esther?
Yes.
Hi, Esther. We're having trouble with the line. Did you want to just briefly introduce yourself, or maybe it's the line
Good
is locked?
evening, good morning. Esther Kobel, I'm a pediatric Plant Child Health Africa. Doctor, I hope that will be a little more helpful. My name is Dr. Esther Kobel. I am a pediatrician and I'm representing the Plant Child Health Team Africa here today. I will be sharing our work. I hope that was better.
Yeah, thanks, Esther. It flowed a lot better then. Thank you. And Salvan, Anthony, welcome.
Hi, my name is Selvan Anthony. I'm just opening my camera. I think there's some problem with my camera. Now it's okay. Hi, my name is Selvan Anthony. I'm working with Intersex Asia as a programs manager. I'm closely working with Ellie. I'm here to support Ellie and also hear from you all the work what you're doing and also try to implement that in our work for the intersex community in Asia. Thank you.
Wonderful. Thank you so much, because we know in the Philippines, members of the CAH community make up a very large part of the intersex community, and you're very welcome, and we're very grateful to have you as allies. Okay, so just going back to the agenda, just wanted to finish sharing a couple more updates after those introductions. Just a quick refresher on Mates for Kids. So we are an international coalition of like-minded individuals really passionate about reducing the preventable mortality associated with CAH by 30% by 2030. And we believe that these efforts will contribute to achieving the SDGs by 2030, specifically SDGs 3.2.1, 2.2, and 3.4. We're taking a knowledge action approach and really sort of, it's a continual approach, bit CQI, continuous quality improvement like, really focuses on understanding the root causes and the problems at a local level, trying to come up with solutions, trying to implement them, and then evaluate how we go with that, and just keep sustaining the knowledge. And that really informs the development of the Mates for Kids toolkit, which is on our website. And we also keep, so publicly available resources are on the website, and more private resources like the recording of this meeting tonight are on the Knowledge Action portal. And we try and leverage events as much as we can. We have quarterly meetings and we break up into different zones. So in December, we'll have a community practice meeting for Western Pacific, Southeast Asian and Eastern Mediterranean regions. And in each meeting, we always try to include a focus on access to medicines, community development, growing CAH communities, and international newborn screening, rather. And I just really want to acknowledge CAH International, who are just wonderful allies. And Marika is going to be giving us a talk there. And having the CAH community at the centre there is so important, because we understand in some communities, CAH communities are just growing and they're quite nascent and new. So we're very grateful to CAH International for the role that they play. So we're working towards 2030. We're here just past halfway through 2024. These are some of the events that we've been leveraging. Time, we started here, you know, time goes very quickly. We'll be at 2030 before we know it, and we're quite mindful of that. So just a few quick updates. The round 3 community development grants are available. Today we'll be hearing from multiple grant recipients, which is wonderful. We recently had a grant drop-in event, and all of the grant recipients were talking together and sharing what they're doing, and it was a fabulous event, learning from one another, and we'll learn more today. The next round closes on the 6th of September. So if you know of any countries who might be interested in applying, please let them know. We're planning to give 40 grants out by 2030, hopefully to 40 different countries. We're already seeing amazing change and achievement, and we'll touch on a little bit of that. And it's amazing what people are achieving. I am excited that at the UN Summit we will have IFCAR presenting, and they do give out larger amounts of money as grants for CAH research, and we're hoping in time that our grant recipients might go on and get, you know, apply for larger grant amounts from IFCAR and others in the future as well. So we've had it's been so busy this year, and I really want to pay special thanks to Katie and our other UN youth reps and clan youth advisors who've played such a vital role in helping us all pull together multiple events. We were at the Commission on the Status of Women run by UN Women. We had a side event there. All of these reports are on the Mates for Kids website. The Commission for Social Development, we had an event there as well. A lot of these, the UN Women event focused on gender equality. Commission for Social Development focused on newborn screening. WHA 77, the World Health Assembly, we had a face-to-face meeting in Geneva. And newborn screening was a key focus then. Small Island Developing States of a side event, and again, newborn screening, and International Neonatal Screening Day was a big focus as well. So we have done a lot on newborn screening, and we're really mindful that we need to focus on access to medicines a lot moving forward as well. So that will, you know, continue to be a focus. Upcoming events, we've got the UN Science Summit on the 11th of September. That will focus on newborn screening again. That's after I've just said we'll focus on access to medicines, but it's coming. Also, Jean-Pierre Chanoine has asked us to let you all know about the first GPED annual meeting that's coming up, and I'd really encourage you all to consider registering and attending that. Paola may want to say more about that later on, but I believe the registration costs for people from low-income countries is very affordable. I think it's something like $15 US or something like that. And if people had trouble with that amount, I'm sure GPED or CLAN would be happy to have a discussion with you about that. But it looks like it will be a great event for sharing. Our next community of practice meeting, as I mentioned, will be in December, and we're looking at having some face-to-face. We're going to apply to the International Pediatric Association. We've been offered a slot for some events in Mexico in May of next year. There've been lots of new resources. On International Neonatal Screening Day, we launched a child-friendly rights flyer, a consensus statement on newborn screening, and I won't go into all of the details, but this is just a snapshot of some of the resources that are coming out. This is a book that Professor Raul from Mexico translated some time ago, but the Colombian communities finding it useful. The Sri Lankan community has been putting out wonderful resources in both Sinhalese and Tamil. There's a great website there in Bahasa Indonesian. There's a school video. Intersex Asia has put together a great report on their recent visit to the Philippines as well. So that's it from me. So right on time, I'm going to finish, but that was just a bit of an introduction. And I'd like to now hand over to the teams from ASPE and Nigeria, just to give us some updates on the issues around access to medicines in Africa, because we understand it's a really big challenge for the CAH community of Africa. So could I please hand over then to Dr. Salwa and also Dr. Elizabeth to share some updates, please.
Okay, can you hear me? Okay, can I share my slides?
Oh, yes, I'll just do that. Thanks, Dr. Salwa. You always have the most beautiful slides, Dr. Salwa.
Thank you. Just a minute. Share. I cannot share the slides. Can you see my screen now?
Not yet.
Not yet.
It does say that you should be able to.
Okay, desktop. Okay.
Yes. Yes, perfect.
Does it show now? Okay.
Yep, that's perfect, Dr. Salwa.
So Good morning, evening, afternoon, everything for all people here. My name is Selwa Musa. I'm pediatric endocrinologist from Sudan and the chair DSDCH focus group in the ASPI group. So I'll highlight about the situation of CH, not CH in Africa, but the access to medicine regarding the CH and DSD, diseases. So the outline of my talk would be a few background, update on the access to medicine and the future plans. So as you know all that Africa comprises 54 countries with multiple ethnic group and various degree of economic development. And there is lack of information regarding access to medicine due to lack of reports regarding CH itself from the African countries. So that's why we created an ASPI CH focus group in 2022, which is created by Dr. Suzanne Sack, which is the past president of ASPI. And thanks for Dr. Liz, who gave me the opportunity to continue on the same mission. Okay, so we created a very quick survey 2022 from 11 countries to highlight the situation of CH in African countries. And then regarding the medicine, we noticed that the hydrocortisone is only available in 50% of time in the African countries, while fludrocortisone is less available in 33% of the time. And you can see here that even the medication, you can see that the medication is, though it's like less cost than the investigation, yet it's not readily available. Okay, so just a few days back, we just posted this question in the ASPI groups for pediatric endocrinologists that, dear colleagues, may you have an urgent response to explore some difficulties regarding access to hydrocortisone and fludrocortisone for CH patient in your country. Is it available? What about the supply? And what is the price of each of hydrocortisone and fludrocortisone? And do you use prednisolone instead of hydrocortisone if it is not available? And actually, we got very nice responses from like 15 African countries highlighting the difficulties in access to medicine. I will start by just a minute. I will start by North African countries, by Algeria, because it reflects the situation in the North Africa. Dr. Asmaha from Algeria, she said that the hydrocortisone is available and reimbursed by Social Security for €1 each 30 tablets of, depending on the brand. But fludrocortisone is not available, brought from abroad by patient or doctors from the Spain, €10 for 40 tabs, 0.1 milligram of fludrocortisone. And the situation is similar in Morocco, but it's less in Egypt, where they have fludrocortisone because they have manufacturer for fludrocortisone, but it's not the same for hydrocortisone, which is not available in Egypt. So Mokhtar from Mali, she said that hydrocortisone is available, but we get it from private pharmacies for $5. But fludrocortisone also is not available and has to be commended from outside for, and it's $170 for fludrocortisone. It's very, very strange. And prednisolone is available, but they don't use it as an alternative for hydrocortisone. From Senegal, we got this response that hydrocortisone is available, but not fludrocortisone again. And we got the supply from the private pharmacies. It's $5 to $6 for hydrocortisone and $220 for fludrocortisone, $230 for fludrocortisone. So it's very expensive. And they don't use prednisolone as an alternative for hydrocortisone. Hawa from Liberia, she said that Liberia is still lacking behind in diagnosing patient with CH. She is only having one patient who lost for the follow-up. And then, but she is having private pharmacy that she could like reimburse the hydrocortisone if she found another case. Okay, so this is from Liberia. Going down to the Abidjan, Dr. Mukundu said that hydrocortisone is available, but some not, at which we use prednisolone, which is always available. Who said that hydrocortisone and fludrocortisone are not readily available in Ghana, but and when found, they are very expensive, and they are getting it from GP from Canada, but still they have to pay, implying we have to charge the patient. And when it comes to that, it's very expensive and it's a problem for the patient. And the prednisolone is available, but we use it when hydrocortisone is not there. The president of ASPI list from Nigeria, she said that hydrocortisone and fludrocortisone are available in the private pharmacies. It's $10 for a pack of 30 tablets, 10 milligram strengths, and it's $25 US for the pack of 30 tablets of fludrocortisone. But even though this may not be sounding much in dollar, but because of the exchange rate is very high, this also count a burden for the patients. Dr. Olumwaki said that she never used prednisolone as an alternative for hydrocortisone. So we have many people that they are not using prednisolone as an alternative for hydrocortisone. Is not there. Dr. Saab and Fominki from Cameroon said that hydrocortisone is available, but it's expensive because they got it from the private pharmacies. And then for hydrocortisone, prices is from $3 to $25. And now it's getting more expensive in Cameroon. And they use prednisolone as an alternative as well. Down to Angola, they have hydrocortisone 5 milligram, not 10 milligram in the country, and they have it from the Pediatric National Hospital, which is very good, or from private pharmacies. Okay. As for fludrocortisone, they don't have fludrocortisone again in the country. Okay, and she never used prednisolone. Celeste from Botswana said that both are available. So Botswana is better than the other African countries where hydrocortisone and fludrocortisone is better supply. They have better supply, and it's free. Given free by the government, but when hydrocortisone is running out of the stock, they switch to prednisolone. Okay, so now coming to the East African like countries, like we can start by Tanzania, I think. Okay, so by Malawi, sorry. Dr. Amos from Malawi said that only hydrocortisone is sometimes available in the country, but it's not usually accessible, and it's also expensive, and fludrocortisone is not available. Edna from Tanzania said that it's not easy for our CH patient to access hydrocortisone tabs, and it's not really available most of the time. And when it's available again, it's not affordable. From Kenya, Dr. Phoebe, I think, thank you, she's here. She said that hydrocortisone and fludrocortisone both are available in Kenya in private pharmacies, and this is the price for the both hydrocortisone and fludrocortisone, and she's not using prednisolone as an alternative for that because hydrocortisone is only available. And coming to Ethiopia, and as Kate know that we have very sad story from Ethiopia when Ethiopia is a very big country with 100 million population, and there is no hydrocortisone, no fludrocortisone. And then when patient of CH is diagnosed, they request patient to buy from abroad, and if they can't, they use prednisolone, but again, with its complication. And coming to Sudan, my country, hydrocortisone was available 50% of the time, while fludrocortisone was available like in low cost in 25% of the time. And prednisolone was used, very commonly used as an alternative because it's cheaper and it's available. And sometimes we add salt to increase the hydrocortisone and to obtain salt-retaining effect of the fludrocortisone. But that was before the war, of the current war. Now, the current situation that hydrocortisone and fludrocortisone has to be brought abroad in a very high price. And many cases had lost the follow-up, and the situation is worsening every day. And we are now communicating with some organization like Direct Relief to get the supply, but we're still awaiting the response. So just to summarize this presentation, that hydrocortisone is available in some African countries, yet it's not really available most of the time. And even when available, it's not affordable. And fludrocortisone is not available in most of the countries and has to be brought by parents or private pharmacies. And more efforts need to be put for us as African candidates to raise the awareness and secure medication to prevent supply and follow up in most of the African countries. Thank you very much.
Wow, that was just so impressive. Thank you so much, Dr. Sawa. Wow. Can I think Dr. Elizabeth was going to give a brief talk too about Nigeria, but yeah, Ellie has a question there. Would you like to ask the question, Ellie?
I just find very fascinating the information. I think it's a lot of information that many of us won't be able to process because it's a lot of information, but it's a good picture of what's happening in Africa, and it inspires me to analyze that situation from that perspective also in Asia. I guess the advantage of this type of information, how you capture it, is that you engage with doctors that are very well aware of the availability and cost of all of this. So that would be the aspect I have to identify how to do. But I would like to learn about this also in Asia, which is an important to be able to have a bigger perspective of what is the current situation. I think the current situation has been analyzed very well by Clan. So, but I appreciate the work you put onto this, and I hope we could access your slides. I think your slides are very important for us to.
Sure. So I think this responses were got from the pediatric endocrinologist or pediatrician responsible for managing CH patient from the African countries, and some of them are here as well, Phoebe, Dr. Liz, and others.
Thank you. I'll hand over to Dr. Elizabeth now because she was going to speak too. Did you have some words to add there, Dr. Elizabeth? To speak about the Nigerian situation?
Kate. Professor Abiola was supposed to
Dr. Elizabeth, could you maybe put your
updates on Nigeria because she's the president of the Can you hear me? It says my connection is unstable.
Oh, yes,
Can you
I
hear
think
me
that's a
now?
little bit better with the video off. Thank you.
Can you hear me now?
Yes, very
Yes.
clearly.
I was saying that Professor Abiola was supposed to give the updates on because she's the president for the Society for Pediatric Endocrinology in Nigeria, and she was trying to work with the Nigerian Food and Medicines Registration Board because the medicines they're trying to bring in from Pakistan and Colombia, they need to give some authorization from the body. Otherwise, they're going to have to pay so much for the medications, which won't make sense at the end of the day.
Good afternoon, everybody. I'm here.
Thank God. She's here.
Welcome.
I actually joined like 10 minutes ago. I just kept quiet. Welcome. Thank you for that presentation of SAWA. It's very, very interesting to see that it's almost the same thing we're all experiencing all over Nigeria. So I'll just share my slides now. Okay. Can you see my slide, please?
Yes, very well.
Okay.
Thank you.
Okay, thank you. I'm going to make it as short as possible because I knew that we're also going to present across Africa. So I'm just going straight to it. And in Nigeria, like I said, when I was presenting my inaugural lecture in 2019, in our 10 years audit, at least in my end center, we had 28 patients with CAH. And asking across Nigeria, we had like 40 that we could actually put on our SPEM registry. And the highest number was still from our institution. And then we find that CAH constituted 35% of the patients who presented with ambiguous genitalia. The children mostly presented late. Only 25% of these 28 presented as a unit. The latest data is that as at September 2023, we have 160 confirmed cases all over Nigeria. We are yet to have another update of our registry. We'll do that, but looking at what is happening in my institution, where we still have the highest number, we are in Lagos, and it's maybe because it's a cosmopolitan place, and a lot of people feel that Lagos has everything. So if they have any health issues they cannot resolve on their side, they come to Lagos. So within 5 years, the number has increased. Between 2019 and 2023, the number has increased tremendously. And in 2021, we actually created the CAH committee, of which Lizzie is the chairperson of the CAH committee. And that committee has driven the collection of data and encourage stepwise diagnosis at centers, especially through a lot of the centers are being manned by pediatric endocrinologists trained at our center in Lagos. And so therefore we've been able to inculcate into them to be able to make a stepwise diagnosis depending on where they are. If the parents can afford all the investigations, they should do it. But if they cannot, we start with at least 2 electrolytes a urea and stepwise. And with that, we have been able to get a high number coming in. And also, we've provided information, depending on where you are. If you're in Abuja, I know there are 2 pharmacies there that you can get hydrocortisone, though irregularly. If you're in Port Harcourt, we have 1 pharmacy. So we've tried to note where all these pharmacies are across the country, so that if somebody is looking for where to source it, they will be able to get in touch. But we in Lagos, we are fortunate, we have like 2 centers, and then we have some other ones that sometimes have hydrocortisone. So we keep tap on them to see how we can use that to increase. So there are more endocrine centers, there are more endocrine centers. We have spread all over Nigeria. This is Nigeria, and I can tell you, we have here, Katsina, Kano, Jigawa, Yobe, Borno, Gombe, Bauchi, Kaduna, Plateau, Niger, Kwara, Kogi, Benue, all the whole of this Southwest, Edo State, Delta states, and most of the areas in the Southeast. So with that spread, we've been able to have more of a pediatric endocrinologist, so that we're getting more. Unfortunately, looking through the registry, I actually saw that most of it were here in the southern part. In the northern part, we have few. And I think part of the reason why they have few is that, unlike here, we have access to laboratories for investigations. Though they're expensive, but we have access to them. Up north, that access is not like that. Even the hydrocortisone, we have access to them down south. Even when you're talking about prednisolone, we have more access to prednisolone in the southern part of Nigeria than in the northern part. And when you now think of the far north, that is very difficult for them to do a lot of things. So I'm not surprised that most of the patients we have are coming from the south. Now, what are our challenges? We have challenges. And the challenges are in diagnosis, management, social-cultural, late presentation, the government itself, and now we are now dealing with the mental status, which we were not, we're dealing with it, but not like now, because now we're having some children that are now entering 21, 22, 24, 26, and with that, we're beginning to see increase in the mental issues that we didn't have to deal with when they were younger. So now our focus is also now having to spread and see how we can deal with that. So how do we do our initial working diagnosis? We try to use, because neonates, yes, in Nigeria, we have centers with primary health centers, but unfortunately, even down south, most of our primary health centers are not functional. Up north, less than 30% are functional. So a lot of birth is being done at the traditional birth attendant's place rather than in the hospital. So most times there isn't much, they don't know how to, the TBAs, who are the main people that do most of these deliveries, don't know how to examine the genitalia. They just look at it. Once they see that something looking like a phallus, they say it's a male. So therefore, the presentation to us is always late. The few we have as neonates were those born in the tertiary centers, where we have pediatric endocrinologists who were able to have a look and then make the diagnosis. So most of the time, what triggers off is start of school. The mom has noticed that there's something wrong, and she's wondering, how am I going to do this? Accidental discovery, maybe a relative who has a medical just noticed, and then the brain. The reluctance of the child to play in school or have a friend, because they know what is wrong. So they don't want to use the same toilet and so on. So nowadays that we're talking about, although it hasn't spread to Nigeria, where we are starting talking, but we know it will soon spread here, where there's no gender when it comes to the toilet, I suppose that kind of reluctance will reduce tremendously. Or the child enters in the secondary school and start developing a breast or start menstruating. That is when they usually will bring them. Or the phallus refuse to grow as expected and remains very short. And you know, in Nigeria, as in all other African countries, there's a lot of issue when it comes to fertility. So anything that will look like their fertility will be involved, we make them to come and bring the child into there. And then we have quite a few coming up as adults, especially in the ONG. I was asking my gynecologist colleagues, and they said they do have a lot of CAH, both in the male and in the female. So these are mild cases, but as usual, they will have problems later. Then there's this socioeconomic issue on CAH. Parents in Nigeria, 100% decide the gender of the child. So irrespective of what you even tell them, they are the ones that assume this is a man, this is a woman, and it's very difficult to change them. Then interactions with patients, especially those who are about to enter the university, they're now questioning identification. Who am I really? Because most of them are on social media now. They have phones, and they're seeing the LGBTQ, and they're reading all about this. And the latest opera in the Olympics has even made some of them that are even younger than that too. I have a patient, is just like 12, is asking me, who am I really? You know, asking more questions. And the society not yet ready fully to accept for open revelation. So the parents can't even tell anybody that this is what I have. They will tell them they have a odd child. And then children themselves are taking actions by not taking their drugs. They will just refuse to take it. Then when it comes to drugs, hydrocortisone, fluorocortisone, and all the other things that you will need for ever making your firm diagnosis are not on the list. They are classified as orphan drugs, which means nobody is actually bringing it in. So nobody has registered it. So I just giving you, I tried to call around and find out, like me, if you were in Nigeria, how much it is. And you can see hydrocortisone tab, most of us we have 5 milligrams. Most people didn't have 10 milligrams. But fortunately, that's okay, because most of our patients on 5 milligram TDS, 2.5 milligram TDS, is as they grow older, that we are now beginning to see those who will need 7.5 milligram, 5 milligrams. So you need the 10 milligram. And even then, you can see, I tried to do this because of the exchange rates that we have at the moment in Nigeria, which is very high. It's making everything extremely high. Before this FX begins to have these, we could say that between $30 to $40 is that's what it is. But now, I mean, 30 cents, that's how much the tablets will cost. So, but now it's like 0.8. And if a child is on 5 milligram TDS, is going to spend almost $72 every month. But the unfortunate thing is, if it was regular, it is irregular. So we have it now, we don't have it. Hydrocortisone is also as high as this when we have the 10 milligram. That one is hardly available. It's more of the 5 milligram. Fluorocortisone, I didn't put anything there because the few places I called, they said they didn't have. And they cannot give me a price because they're not sure how much it's going to cost when it finally comes in. But that's only available. Now, ACTH injection, we need it to confirm, to do our ACTH simulation test. We don't do much of ACTH simulation test nowadays because the parents can't afford this ACTH. So once we are able to do those few something, we start the child on hydrocortisone, hoping that one day we'll be able to do that. So this is between $36 to $50. It's quite high. Before, when I started, we were buying this ACTH at the cost of, even now, if I were to convert it now, it was not up to, it was like $1 something. That was how cheap it was. But see the increase now, it has grown tremendously. Now, the average GDP in, I'm not putting the GDP together in the southern part of Nigeria, because in southern part of Nigeria, most women will be doing something, may not give them much money, but they'll be doing something that will supplement whatever the man is bringing to the house. So their GDP, if we put them together, is like less than $23. That's the GDP in a month. I'm putting it as in a month. And but if you go up north, their GDP is as low as 9, 8, because up north women don't work because of the Islamic religion. They don't go out to work. The few that go out to work are usually the Christians amongst them, and they're not too many. So the GDP should not just classify north like that, because in the north central, it is even better. But upper north, this is what it is reading. So I professed some solutions, and I said, strengthen our clan society. We already have a clan society made up of the parents and the doctors, the carers, but it is more, we try to make it a national thing, but unfortunately, we've not been able to get that up ground because they needed funding, and we didn't have funding to support them. So, but if you could do that, at least I think it will also help. Then collaboration, just like what we're doing now, collaborating with you. And like I said, pediatric psychiatrists become very, very obvious now that if we were not collaborating with our psychiatrists before, we now have to, because we're now having children. No, we can't call them children. We're now having young adults who will need this support. Then the government, advocacy to be listed on the proposed National Neonatal Screen Panel. There's a National Neonatal Screen Panel that is being set up, but unfortunately, they don't even know what is called Congenital Adrenal Hyperplasia. So we have to advocate for that. Inclusion in the health insurance scheme. I think if we can get a way of including endocrine problems, issues in the health insurance scheme, it will actually help the parents, because right now they're paying out of the pocket. They are not hydrocortisone tablets, not the injection. The injection is on the national drug list. The tablets are not, and the tablet is what we need. So we need to get them to put it on it. And then remove all duties, because I've been told that if we bring it in, the amount of duties we're going to pay for bringing in these orphan drugs is rather high. Then drugs, as Lizzie said, we are trying to work with the NAFDAC, but the first stop when we got there, although the DG was not there, was that we were told, do we want to register those drugs? So if we register them, then, and we were told that to register one drug is now 2 million naira. That is close to how many dollars now? $10,000 or something, something. We know $1,000 to $2,000, and it's just too much, because the amount we want to bring in will not justify registering the drug that way. And then we were also told that we need to get a pro forma invoice. So I think I've said that to the people who had wanted to deal with in Colombia. But then the pharmacist now looked at it and he said, the amount they want to sell it to us, nobody will be able to pay. That already it's close to what they're buying it now, and they are not buying. So if you bring it in at this cost, they will surely not buy. It will not make any difference. And so unless we can get a source that can be less than what the source we are trying to get across to in Colombia, we may not be able to make that difference because of the exchange rate. Don't forget, Spain does not have dollars to spend. We are dependent on the pharmacist who has agreed to do it for us. And no matter what it is, he's still going to put a little bit on top of it to at least make back whatever. So we need something that is okay. Now, we activate our discussion with the laboratory. Before we had this discussion with the laboratory, and they gave us discount for 17-OHP, cortisol, DH, everything. They gave us a discount. And so a lot of our patients, and that's why I think it helped us to have that number of patients that we now have. But then they've changed hands. And the changing hands means changing the people who are now running it. The people running it have removed any subsidy they have given us. So we probably have to go back. And then training of health workers. Like I said, most of the birth occurs in the traditional birth attendance place. And I was thinking, and I've spoken to one or two of my colleagues on Spain, that we are supposed to write this grant. And I felt that what we should put this grant on is training the midwives, training the obstetricians, training the traditional birth attendants, training those who take delivery in churches and mosques on how to examine properly the genitalia. We may find out that we actually have much more than we felt. At least the DSD rate will increase. And if the DSD increase and we're having 35%, that means the number of the CAH will also increase. Then campaign on all media. The very first time when I started was to talk on a television by error of omission. They just asked me, what topic do I want to talk about? And I said, ambiguous genitalia. They've never heard that word before. So they said I should come on, and I discussed it. And the next clinic we had, there were so many questions raised by people who were listening. By the next clinic, we had 5 mothers who brought in their children with DSD. And that's how we more. And then, I don't know, this genetic diagnosis mainly for us, for the doctors, so that we can classify our patients better. And apart from that, many of the parents, the culprit who brought this in. That's why the fact that we will now tell them this is a recessive, this is this, show them, but many of them don't believe us. But the few that have traveled and they have had their genetic diagnosis done have come back to tell me, oh, Prof, you were correct. I too have that problem in my family. I didn't know. I thought it was my wife. Most of the time, the husband feels it is the wife. So if we're asking for genetic diagnosis, it's actually to help us, because some wives are being ostracized because they felt they brought something bad into the house. And so it's more than just diagnosing. It's also helping with explaining and getting the help of the father. Because I also have observed that when the father is very involved with the care of the child, most of the time they don't default on their drugs. But once it's the mother alone trying to do that, forget it. That is it. So just this a few pictures of what we see in our site. Thank you.
Thank you so much, Dr. Abiola, for that. Yeah, wonderful. Excellent, excellent presentation. Thank you so much. I think we're learning so much, and we were mindful we needed to focus more on access to medicines, and I think we're really achieving that today. We might keep questions till the end, if that's okay, and keep going with the presentations now. I might ask the team from Kenya, please, to share an update on how they're going with their grant now, please.
Thank you. Let me share my screen.
Yes, you should be able to share it, Dr. Salmu. Yes, it's coming up now. Yep, we can see that. Excellent. Thank you. We can't hear you.
I will take you through the CAH. Can you hear me?
Yes, perfect. Please continue.
Okay, so I'm Dr. Saumu Winnie. I will be taking you through the CAH situation in Kenya. So as as part of outline, will take you through Introduction to Pediatric Endocrine Society Kenya, the CAH situation in Kenya, and the collaboration that is ongoing between PESC, CLAN, MATES for, and the ongoing. So Pediatric Endocrine Society of Kenya is a registered act, and its membership comprises of pediatric endocrinologists. Currently, we have around 15 endocrinologists, and 5 of them are within the public sector. And also, we have associate healthcare workers who have an interest in pediatric and adolescent endocrinology. So within PESC, we have different working groups. Group is usually involved in different trainings on different topics. We have Rare Disorders Technical Working Group, Research Technical Working Group, Diabetes in School Technical Working Group, and we have the DSD Working Group. And under the DSD Working Group is where we deal with congenital adrenal hyperplasia. We have the chair is Dr. Laigong and 3 other members who are all pediatric endocrinologists. So how is the situation in Kenya in terms of congenital adrenal hyperplasia? So currently, we do not have any active newborn screening policy in Kenya. And we have noted that there's positive data for CAH patients. We do not have any national CAH data registry. The other main challenge that we have is the knowledge gap among healthcare workers. And this is in terms of diagnosis of CAH and management. The other challenge that we have is poor accessibility to medication, especially in the public sector. In terms of medication accessibility, both hydrocortisone and fludrocortisone are available. The strength of hydrocortisone that is available is the 10 milligram strength, but most of them are not stocked within the public or what we call the government facilities. Kenya has 47 counties, and each of the 47 counties has what we call county referral hospitals. And in most of these county referral hospitals, there is no access to tablets of hydrocortisone and fludrocortisone. Each tablet of hydrocortisone costs roughly around that $0.3 and fludrocortisone $0.6. And these are accessible from the private sector most of the time. Sometimes within the National Referral Hospital, which is in our capital city, sometimes the hydrocortisone tablets are available, but the stock, there are usually so many stockouts, so it is usually not very reliable. Prednisolone currently is not in use, but at some time it used to be used to manage patients with CAH. Dexamethasone is widely available within the country, but we do not use it for patients with CAH. What about accessibility to diagnostics? So within the National Referral Hospital and most of the private labs, we have cortisol test available. In terms of the electrolytes and imaging, they are available in most of the county hospitals across the country and also within our national referral hospital. However, the rest of the tests, that is 17-hydroxyprogesterone, androgens, urinary steroids, karyotype, and genetic testing is only available in the private labs, and it's usually quite costly for most of the patients. So let me take you through now the PES and Mates for Kids collaboration. So Pediatric Endocrine Society of Kenya early this year applied for the Mates for Kid grant opportunity round 2 2024. And the project title was Enhancing Healthcare Capacity and Community Awareness for CAH in Kenya. And our main focus for this project was Strategy 2 of Clan Mates for Kids, which encompasses CAH community development with focus on Pillar 1 and Pillar 4. Pillar 1 is education, research, and advocacy. Pillar 4, encouragement of CAH support group. And we are so grateful and thankful that Clan and Mates for Kids were able to award us a grant worth 1,000 Australian dollars. And we received this grant on the first week of July. Going through project implementation, how are we implementing this project? So looking at Pillar 1, we have been able to organize for webinars to educate healthcare workers on CAH. We felt that most of healthcare workers within Kenya, they lack the knowledge on what CAH is, how to diagnose these patients, and how to treat these patients. So through the support from the grant, we were able to register an online Pediatric Endocrine Society of Kenya webinar platform, and we are using Google Meet platform. For Pillar 1 and 4, we have come up with a research proposal, which is now at final stages. And also we are coming up with advocacy messages that will be shared within various social media platforms that include the PESC social media platforms. And also within the country, we have Kenya Pediatric Association, which is an association for all the pediatricians within the country and all the nurses working in the pediatric sector. And through this platform, we will also be able to share the advocacy messages that we'll come up with. So CAH webinars program. We have already started our webinars, and on 14th August 2024, we had our first webinar done, and the topic was clinical approach to ambiguous genitalia. We are happy to report that we had 300 participants. One of the pediatric endocrinologists who also sits within the DSD group, Dr. Madhura, is the one who took us through this topic, and the moderator was one of our pediatric endocrinology fellows, Dr. Brenda Oeba. And we got a very positive response from the participants. We are also happy to report that we got participants from across Africa. Our colleague pediatric endocrinologists were able to join from different parts of Africa. The next webinars that are scheduled, we have in September 2024, we shall communicate the dates. We will be discussing congenital adrenal hyperplasia, pathophysiology and management, and in October 2024, complications and follow-up of patients with CAH. Going to the research proposal. So we have come up with a research proposal, the title being The Prevalence of Congenital Adrenal Hyperplasia in Kenya, because we do not have the data. So our study objectives, one would be to assess the burden of congenital adrenal hyperplasia in Kenya, and two, secondary objectives would be to assess the social demographic and clinical characteristics of patients with CAH in Kenya, and assess CAH awareness and challenges faced by patients and or their caregivers in Kenya. So our study design will be a multi-design study, whereby we will have the quantitative arm that will be cross-sectional survey to determine the prevalence, and then we will have the qualitative arm where we will hold focused discussion groups of patients with CAH and or their caregivers to gain insight on their awareness of CAH and the challenges that they face. And we are hoping that after the focused discussion groups, we will be able to encourage patients with CAH to join support group, and these support groups will get support from the pediatric endocrinologists that we have in the country. In terms of advocacy, we are already doing content creation for social media advocacy messages. And also our team, everyone has been given their own, has been allocated work to do. And very soon we shall be sharing what we have been able to come up with. And also we are in the process of developing a CAH protocol. And this would be a simplified and a summarized protocol that healthcare workers across the country can use to be able to diagnose and manage patients with CAH. Considering CAH newborn screening, this one requires a lot of political goodwill, and I would say it is work in progress. And we are happy that we've over the last 9 months since we formed the DSD support group, at least there's some work that is ongoing. And one of the things that we are hoping to achieve in future would be the CAH newborn screening. As I finish, I would like to acknowledge the following. So as the Pediatric Endocrine Society of Kenya, a DSD working group, we are very grateful to Clan and Mates for Kids for offering us this grant. And we are happy to report to you that this grant has really helped us to kickstart our activities. We thank the past president, that is Dr. Phoebe Wamalwa, and our DSD working group chair, Dr. Paul Laigong, for their continuous support that they have given us over the last 8-9 months since we started this working group. And as I close, I would say that together we are more strong and able to achieve more for CAH champions. Thank you.
Wow. 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 Thank you so much, Dr. Salmu. That's deeply humbling and so incredibly inspiring. Congratulations to the entire team in Kenya. I was sitting on a bus with a lady from Kenya, and she said, in Kenya, we get a lot of things done. And wow, I can see that here in your presentation today. Thank you so much. Congratulations to the entire team.
Thank you.
Yeah, just very, very humbling. Now, I'm mindful that we have grant recipients to share updates. So I'm going to, I'll share a little bit of information on indicators right at the very end if we still have time, but I think it's more important that we keep hearing from all of you. So if it's okay, I'm going to ask Dr. Esther from Uganda to share an update. And is Dr. Esther here? I know she's been, yes, there she is. Hi,
Thank
Esther.
you. Hi, Kate. Thank you for chairing the meeting. I'm going to say prayers that the internet stays stable during the presentation. Okay. So let me just put that in PowerPoint. Okay. Yes, good evening and good morning once again to everyone here on. My name is Dr. Esther, and I'm presenting the work that is being done by Plan Child Health Africa. We are part of the round 2 grant winners, and this is really what we hope to use the money for. The project is titled Strengthening Early CAH Diagnosis Through Health Worker Capacity Building for Newborn Screening. Briefly about Plan Child Health Africa, we work really in partnership with Plan, and one of our main goals is really to see that we maximize the quality of life for children who are living with chronic health conditions. The pillars, I know majority of the people here are already very familiar with them, and the communities that we are so far working with and engaged with include the epilepsy community, the CAH community, sickle cell disease, and cerebral palsy. I've highlighted CAH because it's really the focus of our discussion today. So on to the current situation in Uganda. I know globally, we know CAH it's one of the rare diseases, but statistics, at least globally, are known 1 in 16,000 children. But when we come down to Uganda, just like Kenya and most of our African countries, there is really positive data on the prevalence of CAH. At one of our national referral hospitals, that is Molago Hospital, which is the main hospital, and it's like what gets most of the children. There are only 10 children who are confirmed to have CAH, and yet we see many more of them who are there being followed up in the clinic. They have ambiguous genitalia, but they've never really been investigated due to financial costs for the parents. So on to why we thought this study is important is just like the previous presenters have talked about it, the knowledge among our health workers about CAH is really minimal. For me, I know that the only health workers who know a lot about the disease are pediatricians and maybe surgeons. And some of them are not even well conversant with the disease. They really see ambiguous genitalia, but they're not even certain of what they're dealing with. But most of our health workers, the nurses, the midwives, the obstetricians, who are the first people to see these children, know little about the disease. And to top it all, newborn screening is not routinely done. It's not even on the national program. So that for us was a very, very big problem that we thought would be a good starting point for the CAH community. And our objectives are to see that we explore both qualitatively and quantitatively the knowledge, the practices, the attitudes of these health workers about newborn screening. We want to come up with a screening package that is realistic, relevant, but also acceptable by the health workers. We want to see that we measure the impact and the outcomes of our interventions on the health worker knowledges, attitudes, and competences. And our fourth objective is to establish a referral pathway for children who are suspected CAH, and then that could be room for us to build on further research. So the people who are going to really benefit from this study are the health workers. We hope to train at least more than health workers, but our minimum target is at least 60. We are going to do this study in one of the national referral hospitals, Kawempe. It is the main government women and children's hospital in the country. So this receives like referrals from everywhere and really focuses on children.
and mothers delivery. So we know that that hospital is also going to benefit from this study because we are going to build capacity of the health workers there. At national level, we hope to be able to at least establish a referral system to the endocrinologists. We only have 3 in the country, but at least we want to see that the children are able to reach those 3 endocrinologists who exist. And though children are not our primary beneficiaries, they will benefit. The newborns will be able to have immediate and direct linkage to care after screening. And those children who have been diagnosed, their parents will, at least diagnosis will have been made early, intervention started early, and that will be a benefit for them. So about this study that we are planning, it's a mixed method. So we are doing both. We plan to do both qualitative and quantitative data, have some focus group discussions, in-depth interviews with the health workers. We are going to do it at the National Referral Hospital. We only have 12 months to get everything done, and we hope to keep everything within the 12 months period. We are targeting working with the doctors, so pediatricians, residents, obstetricians, and also the nurses and the midwives who handle these children firsthand. And what we hope to do, so these are some of our activities. Since it is a study, we definitely need to write a proposal, submit the proposal for IRB consideration and approval. And that is really what we are working on. We are in the final stages of developing the proposal. It's really coming to shape. We hope to submit really soon. So after we get approval, we'll do a baseline evaluation with the health workers, and basing on our findings from the baseline evaluation and other engagements with the leaders in the facilities and the endocrinologists, will come up with an intervention design that we can use to train the health workers. So we've not concluded yet on how long we shall do the training for, but we hope to be able to conduct at least 2 training sessions for the health workers in groups. And after we conclude the training, we'll do a follow-up evaluation. 3 months, we may extend it to 6 months, but we are currently considering 3 months post-evaluation so that we can gauge and be able to know where they are now. So what are some of the areas that we are going to really focus on in the training is visual screening, so clinical presentation of these children, being able to recognize ambiguous genitalia and act on it. I know that I've seen children born in a facility in our hospital, specifically where we are going, Kawempe National Referral. A baby was born, mother was told your baby is a baby girl. She went home, but like you have had, the child goes to pee and the mother is not sure, is this a girl or a boy? And she wasn't very comfortable. And that is when she went back to the hospital, but she was missed at birth. So that is one of the things that we want the nurses and the midwives to be able to see and know how to pick, but also children present, especially baby boys, with dehydration in the neonatal period, and they struggle to manage them. Sometimes the health workers fail and the child passes on, unfortunately, but that is really, really something that they don't think about, like CAH. So we want our health workers to be able to know that. We want to put emphasis on the tests that can be done, both the diagnostic tests, which are a bit expensive, but also supportive investigations. So electrolytes, they're life-saving investigations that these health workers need to know about. And then want to take them through management and work with them to see that we develop a referral pathway for these children, seeing that we link them to the endocrinologists. So because it's research, we are definitely going to get ethical approval from Makerere University School of Public Health. We're also going to obtain administrative clearance, and of course, we'll emphasize participation is voluntary. So acknowledgements really, to Mates for Kids for offering us the grant. We are very pleased and happy. And of Clan for always supporting us and being there with us on this journey. I've added Makerere University. This is Department of Child Health and Development Center. This is the center that is going to support us with the research, especially. So that is why they are here. This is our team that we are going to be working with. And thank you for listening. And I welcome questions, comments from everyone else. Thank you.
Absolutely brilliant, Dr. Esther. And I just really want to acknowledge the team in Uganda with whom we've been working since 2017. We started with nodding syndrome and then epilepsy, and then CAH, and then cerebral palsy and sickle cell. They just do wonderful work. And what's so exciting with these different grants is that local teams are identifying local priorities and driving local action, and that's always the best approach. So huge congratulations, Dr. Esther. We have 2 more presentations, so we'll keep going if that's okay, and we can have questions at the end. Thank you, Esther. That was just fantastic. Okay, so next up, Dr. Paola, who's from Colombia, but in Africa. Can I hand over to you now, please?
Okay, thank you. Now we share my presentation. Can you see my screen? Okay. All right, it was at the end. Okay, so I'm glad to share with you the progress of our of the work we have done, and also thank you for the grant we received from Clan and Mates for Kids, which has been really very helpful for us. So our progress, we formalized our foundation, which is called Siendo Foundation, and we also went over on 7 out of the 7 tools from Clan's kit tools, and they were applied. We also had our first Colombian CAH club meeting in March 2024. We did the health need assessment and the check score, and I'm going to talk to you about it. And we have a Colombian CAH community developed, functioning, and growing. And we have some priorities, which I talked to you and the partners at the end. So as I said, we used the 7 tools from the Clan's kit tools. They were applied, and they were really very helpful to show us the way and to get to build and to give birth to the CAH Colombian CAH community. This is Siendo. This is our Colombian nonprofit organization, which is in partner with the community of patients. The name is in Spanish, Joining Forces. It's called Uniendo Fuerzas. They have the WhatsApp group and the Instagram. So what were the objectives of the first club meeting? To create the first community of people living with the CAH in Colombia, to understand their most pressing needs, and to enhance their knowledge about this condition. We had the participation of 110 people, 32 patients and their families. We had support of a medical staff, educators, and 20 volunteers of Siendo Foundation. But I think what was most important is the key alliance that was built with La Cardio Children's Hospital, which is a big children's hospital in Bogota, the CAH Colombian community, Siendo Foundation, and of course, always with the support and guidance of Clan and at CAH Mates for Kids. And we had the privilege to have Dr. Kate Armstrong and Dr. Maria Craig with us the day of the club, that the club meeting was held. We had also national experts in pediatric endocrinology, public health, psychology, social worker, volunteers, and with all of them, we addressed all the attendees, their doubts, their fears, and their insecurities. And we also gave some talks, educational talks. We worked in 2 groups. We separate the parents and caregivers were at the auditorium for educational talks. And meanwhile, all the children were outside having playful and educational activities that were led by the teachers of the La Cardio classroom. And they really did a great job with all the children, and they had space and they provided tools to create the Colombia CAH community. So this is the Colombia CAH community together at the end, shouting, "Together we are stronger," and all the work that they did with the teachers. If you would like some more information, we have very detailed information in this QR that I could share. And we also have a video of the day that would explain how we went step by step, if you think this would be helpful. We also did the HNA survey in Colombia. We tailored the HNA provided by CLAN, which served as a template. And then we ended up with 112 questions divided into various segments: the demographic data, the medical history, barriers and challenges, economic impact, and recommendations. All the data gathered from this survey was transcribed to a REDCap database, which was really important for us to get the committee, the ethics committee approval, because it keeps really well the information and the privacy. The check scorecard was applied, and we identified 7 families in the very vulnerable conditions. This is 7 out of 32, which is 21.8%. And since we have the ethics committee approval, there is an article for publication that is in process with the data. So I will share with you some of the highlights of the analysis. So one of the questions was if your insurance covers the treatment. 84.4% of the parents reported that it does. But if you look a little bit closer, we also asked what percentage of your monthly income goes towards your child's treatment or hospitalization. And 90% of the families said that a quarter of their income goes for the treatment and hospitalization of the child. So even though there is coverage, there is a system deficiency that needs to be worked on as well. We also asked them if they had access to information regarding the illness and through what means. Less than 50% received information from their doctor. Mostly, they received information online. So there is also something to work on in this area. We asked them if they had access to internet. And yes, 100% reported having access to internet. So there is a big opportunity to reach them through the internet, and it's something that we have to work on to give them more education since the beginning. We asked them this is some of the question we asked them, but what were the major difficulties for families? And mostly said that access to quality healthcare and education were the major difficulties and the things we have to work on the most. And the best points of the club meeting is that what they liked the most was to meet other people who live like them. And also that there was the birth of the Colombian CAH community, since they had, many of them had never met anybody else that lived with the same condition and had the same difficulties or questions they had. And it was really awesome for them to share that. So we have a Colombian CAH community developed, functioning, and growing. The CAH community has now an Instagram that it has 63 followers. This is the Instagram. They have a WhatsApp group for mothers are the leaders of this WhatsApp group. It has 29 members out of the 32 that attended the club meeting. They established some rules. They did a really good work establishing the rules so the community can know exactly what it is for and how to behave. They have a link to join the community. So when somebody is interested, they send the link. And once they get to the link, they will have some question and they will have to read the rules in order to be accepted. They have some clear goals, which is to expand coverage and that everybody in Colombia can have access and will be part of this community. And so they want educational events and information sharing. And Siendo Foundation is supporting and promoting this community. Actually, this community is participating in a study for the validation of a tool to measure the quality of life of people living with CAH in Colombia, which is led by another big hospital in Bogota, which is Hospital San Ignacio. And the community is being part of that as one of the first big achievements of being together. So what would be the priorities for Colombia or the main challenges for the next month? One, strengthen the CAH community. We need to do an action plan and implement the plan to provide support to the 7 most vulnerable families that we found. We need to continue to strengthen and expand the CAH Colombian community, emphasize advocacy work, and we will be doing a club meeting for diabetes type 1. We are working on improving the access to essential medicine. The SLEP, which is the Latin American Society, is working on a national registry. And we are working on the action plan with Vesalius, which is the lab that you mentioned in Africa. And of course, I would talk to them about the prices and see what else they can offer or how we can find a better solution to help. And we are also working on scaling universal access to newborn screening. The newborn screening in Colombia has a law that was approved in 2019, but the good news is that it has been implemented now because it was approved but not implemented until December last year. And the real implementation began in July 2024. And we are starting to get the children from this universal screening. And, you know, that is really good. And we are very happy about that. Our key partners, of course, CLAN and AdMade for Kids, we really have been guided and are extremely helpful for all the help and support we always have. GPED, Global Pediatric Endocrinology, the hospital, La Cardio Children's Hospital, the Colombian Association, the Latin American Association, the community of patients, all the volunteers, and we now have an alliance with a new lab that is giving us a very special price to help and to have more accessibility to test the children when they don't have the means. And also we are working with Vesalius, which is the pharmaceutical company, and maybe we will get many more great news from them. Thank you very much.
Oh, Paola, thank you so much. That was just absolutely inspiring. This is just the best meeting I think I've been in for a long time. It's so interesting. Paola is our round 1 grant recipient, and Colombia and Sri Lanka were our round 1 grant recipients. And it's amazing to see the impact coming from that first round. And also we did start asking grant recipients to use that format, the pearls and the priorities and the partners, and so really lovely, Paola. So thank you. We will, Katie, we might ask for a copy of Paola's slides so we can create a template to help people in the future as well. So, but that was lovely. Thank you.
Thank you. I was also very I was very happy to hear that they did the questions in Africa, because we have the questions in Latin America. So I thought we could put them together and start to have some data around the world on hydrocortisone and fluorocortisone availability. I could share that as well if you want.
Yeah, wonderful.
Okay.
And we would encourage everyone in the chat there to, you know, connect and share email addresses, and everyone, you know, please don't feel you need to go through Clan or anything like that. Please, you know, work together and be your amazing selves together. So now we have our last formal presentation from the lovely Marika from CAH International, our European representative. So Marika, can I hand over to you now, please?
Can you see my screen? Yes, very good. Thank you so much. Yeah. Yeah, my name is Marika. As I mentioned, I'm from Austria, I also share the video here. I'm from Austria, from Europe, and I'm part of the CAH international community. I will talk to you. The screen changed. You can see the next slide. Yeah. I will talk to you about CAH International. Who are we? And then I will talk also about the topic of CAH and gender, as this is one of the topics we are very much involved in. We were taking part in a UN Human Rights Council meeting this year. And this is a topic which we face globally, and it's a very diverse topic. We have to talk about it. So just before I tell you about the CAH International, I just want to tell you how impressed I'm always by all the doctors we meet. So when we started, for example, our CAH group here in Austria, I thought, oh, how can we start it? And I approached some doctors, and suddenly they all said, yeah, we support you. And that's what I feel and sense now when I listen to you. So the bed endos, you are all such passionate doctors, and it's a real honor for us as patients that we can work so closely. That's what we see now in our groups all over the world, and that's what I feel also in our work as CAH International. Yeah, CAH International, who are we? We are a network of CAH groups and organizations which deal with CAH. So we include patient and parent groups, support groups, however you call it. In Europe, we often call them self-help groups. And so far, we are in contact with groups in about 25 countries all over this world. So we have still lots of contact work to do, but we are developing very slowly, because we are all volunteers doing this work, and everybody who is engaged is also very much engaged in it in his or her own country. So yeah, it's lots of work to do. And we also include organizations like IFCA. This is a French organization funding research on CAH, yeah, and we are very happy to be part of the work of Mates for Kids of Clan. We're also in contact with Magic Foundation. We're doing a great work in India, for example, and just recently I was able to participate at a meeting which Magic Foundation Africa was supporting. It was a talk on CAH in Kenya, so it was very interesting for me to be there. Yeah, as CAH International, we focus on three main parts at the moment. We look at the standard of care, and that's very much the topic Kate is working. Also, the availability of the access of medication is the most important part of care. Then also research. We are connected very closely with the CARES Foundation of USA, and lots of research is done in USA, but in our Western countries on developing medication, new medication, genetic therapy. So this is very interesting for us. And our third focus point is the topic of CRH and gender. So this was actually the starting point of our connection as CRH International. In our European countries, we are very much, we have lots of discussions about who are we as women with CRH? Are we women? Are we intersex people? What is DSD? What is intersex? What's about surgery? So this was our starting point, and now we are involved in this topic, and we want to get a global view on this, and that's where we are in now. So this is CRH International. We are a very loose network. We are not a formal organization right now. It's just too much work to do, but we are there and we connect. And this is the thing we want to do. So CRH and gender is a global issue. As I mentioned, we have discussions in many countries about legal regulations of surgery. So in our Western countries, in Europe, in USA, surgery for girls is available at a very early stage of life. So children, girls with around the age of 1 year old to 3 year old do have surgery, and we face many discussions about that. We also faced discussions on UN level. So last year, the Human Rights Council was the Human Rights Council was discussing this topic, and I will share a little bit more briefly. And it's a topic that CRH and gender with very different views and very different life experiences of those who live with CRH, and I also will share about this. So to let you know about the discussion on the UN, as this really covers the whole world. So in March this year, there were discussions in the Human Rights Council about a resolution which is called Combating Discrimination, Violence and Harmful Practices Against Intersex Persons, which was brought in by 4 countries together. And there were really long discussions. In the beginning, it seemed, okay, it's quite clear what they are talking about it, but then there were the discussions which we all face in all the countries where we have these discussions. For example, here in Austria, we had the same discussion, is which terminology or definition should be used if we talk about that topic. If it depends from which side you come. We have the DSD terminology and the definition of this topic, and then we have the definition more coming from the activist groups about intersex. And this was a really long definition, a long discussion, and I could give a statement on behalf of CRH International to a discussion, being aware of the fact that what I know about CRH globally is still a jigsaw. Yeah, it's parts and parcels we know, and we get to know more, and we try to get the full picture. And then in April this year, there was a vote on this resolution, and it was not a clear resolution. 40 countries of the 47 delegates voted with yes, and 23 countries absented, and this was a very strong sign. the whole resolution is talking about intersex, and it's not so much about DSD. And here you see how the countries voted. So you have many European Western countries which voted with yes, but Arab countries, African countries abstained to this, because the whole discussion about intersex is moving very much or focusing not so much on medical issues, and lots of groups said we want, but this topic has to be discussed on the basis of medical topics. So I have to move here. Yeah, the resolution, and always if you have the discussions about harmful practices against intersex persons, the discussion is always what are medical necessary interventions and what is medically unnecessary. And this is where the opinions are very diverse on. The resolution also says that the UN has to prepare a report, and that civil society groups like CRH International can share something for this report, and there will be a panel discussion in 2025 on this topic. Yeah. For us, the challenges in this discussion, or also for this report, there are several challenges. One, what I see now is that we have, in regard of CRH, we have so many different situations because we have such different settings. If you look on this side of this chart I'm sharing, like in Europe, in USA, we have newborn screening for quite some years, for decades already. So we have early diagnosis of CRH, and we have very early treatment with hydrocortisone. So the androgenization is not moving forward. And we have very well performed surgery in our countries. So at a very early age, mostly. And what I see, and I'm so glad that I can listen to the seminar like on Kenya and what you shared today. We have so many countries in this world where we do not have newborn screening, and where what many of you shared, there's such a late presentation of children with CRH. So they have late, no, or insufficient treatment. And we didn't talk in this setting because Mates for Kids is mainly about access of medicine. We don't discuss so much about surgery, but for me it would be interesting in which countries surgery is available. Is surgery available, or is it not a topic at all in so many countries, because you just try that children with CRH survive? So we have these different situations in the different settings, and in countries with newborn screening and early treatment and well-performed surgery, we have so many women who say, "Oh, I'm a woman. I'm not intersex. What has the intersex topic to do with me?" So it's not a clear thing that everybody with CRH automatically can identify with the whole intersex discussion or intersex identity. And this is one of the challenges we also face in CRH International, that we have two very strong opinions in those who are affected by CRH. We have those who say, I'm a woman with CRH, and I am glad I had surgery when I was a child. I'm glad my parents decided for me as a child to have surgery. This is also one of the important discussions, who can decide for a child. So the UN resolution goes very much to the informed consent, that only surgery can be performed only when a child consents herself for surgery at a later age. But from the results in our countries, we know that early surgery has clear advantages. So we have these views from those living with CAH. And on the other side, we have those who say, I'm intersex, I'm inter, my gender identity is inter, or they say I'm intersex and live as males, or they are intersex and live as women. So we have the whole spectrum. In our European countries, we have discussions with intersex groups who say surgery is IGM, intergenital mutilation. They compare the surgery with female genital mutilation, and I personally feel you cannot compare those two, and it's not right to use the term, because female genital mutilation is definitely a criminal act, and intergenital mutilation or surgery of girls performed by doctors is such a different thing. So we are facing this discussion. And we know that some women or some intersex people say, I wished I would have had the chance to decide for myself about surgery. So this is what we are facing at the moment, and I think I'll come to the end. Just to I also have here a chart about legal regulation. So in Europe, we have some countries who have already legal regulations about surgery. We know that in India, Tamil Nadu, they have a law already. So not just the European countries are discussing about legal regulations. Brazil at the moment, we know that USA had several drafts on laws already. And yeah, what we see is CAH groups, like here in Europe, we are able to influence the legislation when we come into the discussions. And the questions we ask ourselves: what is the situation we would like to have for children with CAH? What would we like to have for families? Is a ban on surgery a solution, or should decisions be made on surgery on the individual basis? And this is only for the topic in our countries where we have actually surgery. So I'm very glad that we are linked to Mates for Kids, to Kate, and to Clan, and also to get in contact with all of you to discuss also these topics. Thank you so much. Thank you.
Thank you so much, Marika. And I just really want to thank you as a fellow member of the CAH community, because you volunteer your time, and I think that this work, you know, must be, you know, it must, you know, give of yourself, and I thank you for that, and I thank you for being so open to the situation in low-income countries. And it was a privilege to introduce you to Jeff, who is with the Intersex Asia community, and I know it meant a lot for you to talk with Jeff and learn from Jeff as well. Ellie, did you have a question there?
Yeah, and I just want to thank you for all of you who made your interventions, and also Marika, and I just want to say nice to meet you. Your presentation was quite eloquent. I think maybe we already know each other. But yeah, I think that like this area of surgeries require a lot of nuance, and the conversations are full of nuance in all areas of the dimensions. I think there has been lack of communication into different areas of work. I was connected, or like I was part of the work with the in Geneva when this was happening. But like in 2022 when they were talking about ways for protecting intersex children or persons with variations of sex characteristics in terms of discrimination and violence. I am an intersex person that has experienced discrimination because of my appearance, not because of how the anatomical structure of my genitalia, or if I have a gonadectomy at 8, like regardless of my complex medical past, I have been discriminated just because of my appearance. So I think that this resolution at the UN was intended with somehow the intention to recognize that people like Iman Khalif or people like me could be discriminated just because of the way we look. And that's not always connected to genitalia. And I think that that's important for all of you also to be aware that everyone has characteristics often associated with sex, and those could be a reason for why we are discriminated. And obviously, surgically speaking, our genitalia may be different, and those differences could be fixed with surgery, which would be helpful if we would like organs to be functional, especially in the ways we understand these organs. I guess in my personal experience, I can't speak too much about that because fortunately, the only surgeries that I regret were the gonadectomies. But I know people that have not been very happy about these particular surgeries. I think not in the CAH community because that's another area, but like the people that I have met or mentioned that it's important to embrace nuance. And the good news is that there's been some work done with multiple organizations and bioethical agencies around the world, especially with Oxford University. You maybe know Brian Earp. He's been writing a lot about these issues, like trying to get the nuance and especially from the biomedical aspect. And we are gonna release like a sort of like a statement with like 150 and more doctors and so forth, and it's going to be released soon on like what's this nuance aspect of when the surgeries may not be necessary. Is keeping in mind the particularity that each person and the relationship they have with the patient, the doctor, and all of that. So I think that's what I had to say. Sorry, I know it's a very complicated issue and it's a controversial conversation that is not the space to have, but I just really wanted to share this as it also relates to other conversations that we're having in Africa. I know that this is an issue that requires a lot of effort into understanding deeply, but I'm also offering my understanding of this issue. I've been working on this issue for 5-10 years at UN level too, and my mom is a pediatrician. I want to make this very clear to all of you. My mom is a pediatrician, so I think we all have some lessons that I could share on how has been that relationship with my mom, how has been that relationship of me understanding myself with a body that appears to challenge every expectation around but also at the same time, I'm very glad to be able to be with all of you and also for using my expertise into helping this community to find solutions so we can all thrive and enjoy a good life, right? Which is at the end of the day what we all want. So thank you so much for all your work, and I appreciate it. And it's almost 3 a.m. here. Oh my gosh.
Yeah, thank you so much, Ellie. And I think especially your expertise as a pharmacist is something that we're going to harness as well. So, and I might introduce Marika and yourself outside, but I know, Marika, you've met Jeff, and that was a great starting point. But yeah, Marika's gone to a lot of effort to understand the situation in low-income countries, I know, and it's such a complex topic, and I think you always speak about it so clearly, Marika. I'm mindful we're right on time. I'm sorry I haven't had a chance to talk about indicators. Dr. Paola touched on them. I keep saying that we want to have indicators as a real focus moving forward. And I guess that I just say that we do have, Paola spoke about the different tools that we do have, and we'll get into that. There's some traffic lights. Colombia is the first country to have completed all of the indicators. Sri Lanka's done some great work with the check tool. Here's the health needs assessment happening in Colombia, and here's an example of how we'll get the equity scorecard. So they're just some visuals, because I want everyone to know that numbers. If we're going to reduce mortality by 30% by 2030, we're going to have to show how we're doing it and have some numbers to back that up. But that's for another time. Thank you all so much. This has been one of my favorite community of practice meetings. Thank you all so much. Please email one another. I've written down all the participants, so we'll send out an email with all your email addresses. But thank you all so much. I'm sorry we didn't get a lot of discussion time at the end, but it's 3 o'clock in the morning in some places. It's 1 o'clock in the morning here, and and we'll call. But thank you, everyone, and we'll be in touch. And you're all amazing. You're literally all superstars, and you're changing people's lives, and we can't thank you enough. So take care, everyone, and hopefully we'll see you at the Science Summit in September. Thanks, everyone.
Thank you very much.
Bye.
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 Nice to meet you.
Bye. Take care.
Bye.
Thank you.
Bye.